Hi, this is Joan Palmieri from Benedict Billing Solutions and Learning Community, and I'm really delighted to be here today and share this information with you. It's one of many educational pieces that I have on my Benedict Billing Solutions LinkedIn page, where you'll find videos, white papers, quick tips, all sorts of things that will help you. I share new information every week on medical billing, coding, and maximizing reimbursements, so be sure to check it out. Okay, let's get started with today's video. Hi everyone, this is Joan Palmieri from Benedict Billing Solutions, and I really wanted to do this series because I've had so many questions about coding, billing, and generally the new policies surrounding telehealth services. As everybody probably knows by now, there was an expansion passed by Congress waiving key telehealth requirements for providers and patients on March 6th. It essentially allows a lot more flexibility to offer telehealth services during the COVID-19 emergency. Currently, Medicare is calling the policy changes temporary, but nobody really knows when this is all over what policies will stay in place. Now, whether you're using telehealth services now or you were thinking about starting it eventually, all of us really need to dive in deep and adopt this technology. My focus will be on outpatient billing, coding, and reimbursement, but I'll also give you an overview of the policy changes. I want to start with a quick review of Medicare telehealth before and after COVID-19. And if you have any questions, please reach out to me anytime. My contact information is up on the screen right now, and I'll put it on the last slide as well. Okay, let's jump in and get started. Before COVID-19, there were a lot of restrictions around how telehealth services could be administered in order for the provider to bill for the services. For example, the patient had to live in a designated rural area and had to travel to an approved facility in order to engage in the video conferencing service and in order for the provider to bill for the service. But after COVID-19, many of the restrictions have been relaxed, including the patient can live anywhere, and the patient and provider can actually conduct the visit from their homes. From a billing perspective, Medicare is considering the evaluation and management telehealth service as a regular in-person visit, and they'll pay the same rate for the E&M service. I want to mention, because I had a lot of questions about this, that the service doesn't have to be related to COVID-19. It can be any kind of telehealth E&M service. Here's a list of all the provider types that can offer telehealth services. And the easiest way to understand as to whether or not you can offer telehealth services is to think about it like this. If you can provide evaluation and management services and bill for them in your normal office setting, then you can provide and bill for telehealth visit services. Let's take a look at what visit types are appropriate for telehealth services. Now, I want to give you an easy way to determine this, and it really boils down to if you can take an HPI and examine the patient without touch and instead use visual live video or even examine a still photo, you can conduct a telehealth service. Now, in the dermatology example I provided, the medical provider would take the HPI and have the patient move the video screen so the provider can actually see the affected area. And just a note that it's okay if you're conducting a telehealth visit and you determine that the patient needs to come into the office. There are three main types of telemedicine visits that Medicare and most insurers cover. I want to give you a tip that really you should be calling your insurers to find out what they cover and any requirements that are specific to those insurance companies. But the very first one is the Medicare telehealth visit, and that's the most profitable and lucrative service. There are requirements around the telehealth visit, and I want to review those with you right now. So they do require synchronous audio-visual communication platform, and all that means is that you have to be able to speak to the patient and you have to be able to visually administer the service. The patient and provider are both able to engage the visit from their homes. It does require the patient consent, but that can be verbal. And the patient has to be an established patient, so it cannot be a new patient. And the way you're going to document this is the same way you would document an office visit. Basically, just pull up a visit note, note that it was a telehealth visit, that the patient gave verbal consent, and you'll document it exactly the same way you would document an E&M service in your office. And in fact, you'll even be reimbursed the same way you would be reimbursed for an E&M service in your office. So in terms of coding, you want to be sure to use the place of service code 02. And as I said before, other insurance companies might have a different way of coding, and you need to call each one of your payers and see how they want this telehealth service coded. I know that some insurance companies are requiring a modifier 95 or GT. Now, in terms of the actual codes, you'll use the same E&M codes, the 99211 through 99215. Okay, let's move on to number 2, the virtual check-in. And the virtual check-in doesn't require video like the telehealth visit does. Now you can perform it through synchronous or asynchronous communication like text, email, or telephone. And actually all 3 of these types of visits require patient consent, which can be verbal. It has to be an established patient, and the patient and provider can engage in the visit from their homes. For the virtual visit, it's really to determine if the patient needs to be seen for a more comprehensive visit. Also, in order for this to be an appropriate visit type, the patient cannot have been seen for this particular issue in the past 7 days. For example, if you're already treating someone for a condition in the past 7 days, you're not going to be able to do a virtual check-in type of visit. It can't lead to a visit within the following 24 hours or next available appointment. So for example, if you're talking to a patient and during the virtual check-in you decide the patient needs a full appointment, then just get on an actual telehealth visit where you'll do a synchronous audio-visual visit. Now, you cannot double dip for this, so if you wind up going on to the telehealth visit, that's what you'll be billing for. Once again, if you can bill for an E&M service, then you can bill for a virtual check-in. Now, how do you document for a virtual check-in visit? Well, it's really easy. Just open up a note, indicate it was a virtual check-in, and the patient gave verbal authorization. Note the method of communication. Note at the end whether or not you recommend the patient to be seen. And the important part for getting paid for this service is to document the start and stop time, because this service is, the payment is based on time. Now, the codes you're going to use to bill this virtual check-in service are based on 5 to 10 minute visits. So document the time you spent, use place of service code 02, and you have 2 CPT codes to choose from for the visit, the G2012 and the G2010. The G2012 is a brief communication, technology-based service, virtual check-in by a physician or other qualified healthcare professional who can report evaluation and management services provided to an established patient and their 5 to 10 minutes of medical discussion. So in short, this is a visit you're conducting through email or telephone call that lasts 5 to 10 minutes but doesn't include evaluation of a video or image. On the other hand, a G2010, if the established patient is sharing a video or image, then you're going to use the G2010 when you bill for your virtual check-in. The third one is the EVisit type. And EVisit types are different in that they're only performed through asynchronous communication, like a patient portal or some other type of secure digital application, and it doesn't require a video. The communication has to be initiated by the established patient, and you do still need to get consent, which can be verbal. And like the others, both the patient and the provider can engage from their homes. Now, the communication can be up to 7 days. The patient can't have had an E&M service within the past 7 days for the same issue, and they cannot have a face-to-face E&M service within 7 days of the initiation of the online service. Now, the way you're going to document this is you're going to pull up a note, document the virtual check-in, the method of communication, and if you're recommending to see have the patient be seen. Note the time spent for a 7-day window, and that'll include the time reviewing client records and the tests that are related to the current concern. Now, regarding coding, take the total time you spent with the patient, including reviewing videos, tests, images, etc., and add up the time over the period of 7 days and determine the code based on the total time. The 7 days starts when the medical provider, with the medical provider's initial review of the patient-generated inquiry. So the codes that you're going to use are 99214, 99422, or 99423. Now, the 99214 CPT code is for 5 to 10 minutes with an established patient, online digital E&M service, and up to 7 days cumulative time. The 99422 will be 11 to 20 minutes. The 99423 is 21 or more minutes. Now, these services can also be provided by qualified non-physician health professionals who can't bill E&M services. So, for an example, like physical therapists. But you still can bill for these services, and the requirements are all the same, except that you'll use different codes. So for the 5 to 10 minute, you'll use G2061. The 11 to 20 minute, you'll use G2062. And finally, for 21 or more minutes, you'll use G2063. Let's look at HIPAA and how the rules were greatly relaxed with this waiver. Before COVID-19, in order to provide these 3 types of telehealth services, you had to utilize a HIPAA-compliant way of communication. So, for example, the video conferencing service you used had to be HIPAA-compliant, and you had to have a business associates agreement with the video provider. However, that's all changed with the waiver that was signed on March 17th. The OCR issued a statement saying they're not going to issue penalties due to non-compliance with the HIPAA regulatory telehealth requirements. That means you can use applications like Skype and Facebook, Google Hangouts, Zoom, Facebook Messenger video chat. However, you cannot use public-facing applications like TikTok, Twitch, or Facebook Live because it has to be a private one-on-one conversation between the patient and the provider. In case you aren't up and running with telehealth services in your practice yet, I'd like to give you a few tips on how you can get started. First, take a look at all of the services that you provide and try to identify those that would qualify for telehealth. You can let all your patients know in the form of an email or a letter that you've got telehealth services available. You can contact your patients and screen them to determine if they're good candidates for the telehealth services you're offering. Set up a dedicated private space with good lighting and audio where you're not going to be disturbed. And if you're working from home, make sure that it's a private place to ensure patient privacy. And finally, have an office plan for patients that are not good candidates for telehealth services. And finally, here are some great resources I wanted to share with you. I truly believe that it empowers all of us to share and communicate knowledge with each other. Thank you for watching, and be well.